So before I so just before he starts speaking on the next topic, I would like to say that as soon as he finishes, before you go out for tea or coffee, all of us will assemble here for a group photograph. Everybody here. Okay. Now that I've made that announcement, I invite Ullas to give his talk.
So this is going to be easy. This is, I mean, probably I'll finish in 5 minutes time only, and this is uh, this is about atezolizumab plus chemotherapy in first line extensive stage small cell lung cancer. My disclaimer, and I mean, whenever you talk about small cell lung cancer, my first reactions actually are like this. If this is actually non-small cell lung cancer and this is all the target therapies and immunotherapies and everything, this exactly is small cell lung cancer. I mean, nobody really looks at small cell lung cancer. It's almost like if you're sitting in the company of Senthil and Sahoo, nobody looks at me. But I could not put Senthil and Sahoo as this too, so I thought I thought locha zyada ho jayega. So I put the other regimens over there. So Sahoo doctor, sir, you can go now. I was just waiting for you to make this joke and then you can go now. Okay. My subsequent reactions on that were, have patience. I mean, even non-small cell lung cancer was not good. Everybody will realize, Dr. Govind Babu sir used to tell me when I was doing DM, you should do a thesis on lung cancer. I said, why? He said, you'll get OS very early, no? In 7 months, everybody will die. And at that time, breast cancer used to be the flavor of the towns and gallons and SABC, everything. Lung cancer was not there. This is how we started. This is how the early days of ISRO were. The rocket was brought on a cycle and a satellite was brought on the bullock cart. This is how we started, and look at where we are. It took us 40 years, but we are there over there. So what is the rationale for IM power 133? Small cell lung cancer, absolutely. If you think L858R is a tough nut to crack, I mean, this is the toughest nut. Small cell lung cancer, ETO carb. The 5-year overall survival is only 2%, median OS is only 10%. And everything has been tried, triplet, quadruplet, one therapy, two therapy, nothing really seems to have worked. And the 5-year survival in this is only 2%, only with chemotherapy. Even in a stage 1A disease, the 5-year overall survival is 21%. That's less than a pass percentage mark for a Kendriya Vidyalaya graduate, a student like me. 35% is the pass marks, and you don't even get that much marks here. So against this background, atezolizumab versus plus chemo was tried versus placebo versus chemotherapy. We gave atezo for 4 cycles, atezo plus eto carb. There was no cisplatin. It was compared with the placebo, 4 cycles of chemo, and then atezo was given as maintenance till the time the patient had progression. The primary endpoint was OS and PFS, and the secondary endpoints were here. Now this was a trial in which OS was the first, was a primary endpoint, and if we see here, more than, I mean, this was the first study actually to show an increase in OS in the stage 4, in the extensive stage small cell lung cancer, a 2 months advantage. But what is more important actually is the tail of the tail, as we all very fondly remember that, and more than half of the patients in the atezo plus chemo arm were alive at 1 year. That is not something which is the mean, a very small achievement. Again, this was an 18-month analysis, and then we got a 24-month analysis. A 2-year overall survival was 22% versus 16.8%, and the median OS remained 12.3 versus 10.3. So, people who are responding are beginning to respond. But that is old news. Why we are here today is to learn about the 5-year overall survival data of small cell lung cancer, absolutely unheard of. And if you actually remember, even in nivolumab, the Checkmate 1757 study, the 5-year overall survival was 16% in the nivolumab arm versus 6% in the docetaxel arm. So I'm just comparing this to a second line OS. Numbers are very, very small. So the umbrella A was an extension study. People who were on the survival follow-up of atezo, eto, carb, or who were continuing to have atezolizumab were taken. Very minuscule 18 numbers were taken out of a 201, but that's the way small cell lung cancer is. This was the IM power 133 study. This was the umbrella study, and if you look here, people also had brain mets people also had liver mets. So small, two number of patients out of 18. But it's not that people with liver mets do not survive. I mean, if you give them atezolizumab, that's the only positive thing I can find out from here. The long-term OS, if you look here, the 5-year overall survival is 12%. So again, it just to remember, nivolumab was 16%, here is 12%, absolutely small numbers, but there are a very certain minuscule number of patients who may just get 12% survival. Again, patients, all of them probably responded very, very early, had a partial response, and then were taken. Safety outcomes, you don't expect any new safety signals after 2 and 3 years of immunotherapy, and nothing new we really actually got over there. So is this trial only, is this long-term survival only there for atezo, or is it there for other also? In the Caspian study also you have a 3-year data. In the pembrolizumab study also you have a 3-year data of 16%. So I think there is a small minuscule subset of patients who are actually going to respond well. Which are those patients? Should we be doing a genomic classification? Should we be doing the small cell, the ANDI classification? We did a study for that also. But you know, we still don't know which one is there. Can we now utter the C word, that is the control, long-term control word for small cell lung cancer? Early to say, small numbers, but there are certain patients who can do that. So just to conclude, there is a 2%, there is a the 12% 5-year overall survival rate with atezo etocarb, and that's the highest number which has been reported till now. But that is not why I accepted this talk. Why I accepted this talk was our data. 22 patients of small cell lung cancer, which we have given atezo etocarb over the last 1 or 2 years. It is written, smokers and non-smokers 7. That's a misnomer. Probably the insurance purposes they would have made them written 7. I mean, all of them actually had were smokers. Brain mets were present in 23% people. ECOG PS 0 to 2. These are the people which we gave immunotherapy actually. A good response rate 72.7%. A 1-year overall survival is 42%. Out of the 22 patients, I can remember 3 patients who have now gone beyond 1.5 to 2 years now. So we are also coming to somewhere around 10 to 12% of people who will live beyond 5 years. This is the OS data, nothing to really great show graph. You can find plenty of faults with 22 patient data, but that's the data that we have. One thing which we found out peculiar was people who had brain mets versus people who did not have brain mets. People who did not have brain mets were the ones who did not do very, very well. This is just a patient basically which showed, which was started on atezo etocarb. We have gave atezo and then atezo maintenance to this patient. It's been approximately 1.5 years for him onto atezolizumab and is doing absolutely fantastic. So to conclude, although there is very minuscule, but there is still hope in small cell lung cancer also. And just in case you were not amused and impressed by the presentation, just look at this guy. 5 years back, no one knew this, and this guy got Katrina cap. So maybe small cell lung cancer also will get something. Senthil, we also have hope. With this, thank you. We all break for tea. Thank you.
Ullas.
No questions.
Yes, there are. So
the mic is not working. Dr. Parikh is waiting. I'm not.
The OS, what you showed about CNS mets present versus not present.
Yes.
Is it your routine practice to give prophylactic cranial irradiation? You do. So all these patients who did not have received CNS?
Yes, we have been giving. In fact, I will go one step ahead and say that we have also in, I would say 20% of people been giving thoracic RT. So people with extensive stage small cell lung cancer, after 5 cycles of or 4 cycles of atezocarbazone, if they have only thoracic limited disease, we do go ahead and give them thoracic RT also. And we have had no complications. Out of the 3 people that I've got, 1 patient has got thoracic RT, 2 of them have not got. But it is not very detrimental. I think it should be, again, be selected. If your patient is in a good PS or small volume of disease without anything, you can give that.
And since all these patients could afford atezolizumab, I'm sure you must have done NGS panel also on these patients.
Yes, we do. So small
was
cell
the
lung
chemo
cancer
outlier different from immuno outliers?
No. We did a very interesting study for the, since you have brought it up, we got, I mean, that was an ESMO Asia oral presentation also, where we compared the 4 different types of small cell, that is the A, N, D and I, the non-inflamed versus inflamed, and we did the IHC markers. We are now doing a molecular marker, the NGS for them, and comparing them with the IHC markers. we could have got a more better thing, but not everybody gets Atizo. So if Roche decides to sponsor atezolizumab for everyone, I can do that study, which they will not. Thank you. Thank you.
Thank you very much. Requesting everybody to come.